Assalamu alaikum. Today we are here with another important topic, the complications of laparoscopy. And these complications, we already recorded and discussed a lecture about the vascular complications in laparoscopy and what are the mechanisms and how to diagnose them and then how to manage them. And this is a lecture about the gastrointestinal complications in laparoscopy. So let's discuss the etiology, the diagnosis, and then management. The gastrointestinal complications can occur in all types of procedures, whether laparoscopic or robotic or open. However, in laparoscopy or robotics, they should not be underestimated and the optimism should be kept as low as possible because the complications of gastrointestinal tract, which are overlooked, can lead to disasters. The mechanisms of injury can be sharp injury, or it can be an ischemic injury. There can be injuries to the mesentery leading to ischemia, or there can be injury by the various kind of energy sources. The chances of gastrointestinal complications, they decrease with increasing experience of the surgeon. However, the chances increase with increasing complexity of the procedures. The risk factors are as follows: the varus needle injury and the trocar injury. That is the first trocar injury. The entry of the first trocar, which is usually blind because there is nothing inside to visualize it from the inside, and the varus needle at the time of pneumoperitoneum creation, it accounts for about 25% of the complications in laparoscopy. So in order to avoid these 25% of injuries, maybe to the gut or the vascular structures, an open laparoscopy or the creation of a pneumoperitoneum by an open procedure, that is Hassan's technique, is recommended. And if you are performing it through a closed technique, then an adequate skin incision should be made. Like, for example, if you are placing a 5 millimeter port, a 6 millimeter incision would be better in order to avoid any trocar complication. Or if you are placing a 10 millimeter port, then an 11 millimeter incision should be better. The reason is that if the incision is not adequate, and if there is 10 millimeter port and a 10 millimeter incision, so the skin incision is not going to allow the 10 millimeter port to go in. So you have to apply an extra pressure, and that extra pressure, when it suddenly gives way, it can lead to injury to various structures. That can be solid organs in the form of liver or spleen, or the kidney, and that can be in vascular, can be aorta, inferior vena cava, renal vessels, or the iliac vessels, or that can be small bowel, the stomach, the duodenum, the ileum, the large gut, etc. So adequate incision should be made for the trocar to minimize the risk of such complications. Adequate relaxation or curorization. A trachurium is given as a muscle relaxant to the patient in whom laparoscopy is being performed. So one has to wait for the relaxation to get complete. So when all the skeletal muscles are relaxed, only then one should place the trocars and the varus needle. And a good technique should be emphasized. In varus needle, the good technique would be that you hold the varus needle by like a dart, and from where you are holding it, it should be 3 centimeter plus the thickness of the abdominal wall. So by that way you can reduce the chances of injury inside the peritoneal cavity. And for the trocar, you have to grab it like a pistol, and then you have to grab it lower down as well, at around 2 to 3 centimeter from the tip, so that the sudden movement of the trocar should not get any injury inside the peritoneum. And then a rotatory movement is performed rather than only pushing. So this will be a good technique. If there are previous surgery or if the procedure is advanced, there are 70% chances of the complications. So initially during the learning curve, the patient selection is really very important. And other injuries may be, the mechanisms may be monopolar, like thermal injuries, the monopolar, the bipolar, the ultrasonic, or the ligashore. And there can be mechanical injuries in the form of retractor, like for example, a liver retractor, which is a fan retractor, or the retraction of the spleen during the procedure can lead to injuries, and can lead to injuries of the gut as well, to the mesentery of the gut, leading to ischemic injuries. And in late cases, there is necrosis. So these are the mechanisms. Okay, the bowel injury, why is it so dangerous? It's because there is delay in diagnosis. So anything which is delayed, the delay in diagnosis can lead to delay in the management, and by the time you diagnose, the patient may already be in sepsis or a septic shock, leading to multi-organ dysfunction syndrome, and the consequences are a mortality. So in the 15% of the cases, they cannot be diagnosed during laparoscopy. They are overlooked. You don't even know you are through and through the small bowel, and you have performed a nephrectomy. You are through and through the mesentery of the small bowel. So that's why it's really very important to pay attention to the bowel injuries. And in delayed cases, the mortality can go up to 20%, from 3 to 6% in early diagnosed cases. What are the principles? The principles, whenever there is a bowel injury and is diagnosed peroperatively, you must ask 3 questions. Where is the injury? What part of the gut? Is it stomach? Is it duodenum? Is it jejunum, ileum, ascending colon, transverse colon, descending colon, or the rectum? Where is the injury? Because the duodenal injury is always different, and they are treated differently, and the mortality is quite high even after treatment. Then how many injuries are there? Is it a single injury at a single point, or there are multiple injuries involving different segments of the gut? And then you have to see how deep is that injury. Is it serosal? Is it full thickness injury? Or there is injury to the mesentery leading to ischemia of that portion of the gut? So those 3 questions are important. How can sharp injuries occur? The sharp injuries can occur, number 1 is the varus needle. So varus needle is sharp. Most of the times when you create an pneumoperitoneum and then you place a visual port, and then the principle is that immediately when you get inside the peritoneal cavity with a visual port, you should see where is the varus needle and where is the tip of the varus needle. And quite a few times even I have noted that it is through the mesentery, or it is through the small bowel. However, we had to do nothing. Just in one case, we had a prolonged stay and had to keep the patient for 5 days in our ward, and he developed distension as well, but there were no signs of peritonitis or sepsis. So we kept him on a fluid-only regime already, and gave him IV antibiotic, metronidazole as well. And we kept him in our ward, and after distension, we gave him a little glycerine suppositories per rectally, and on 4th day, his bowel movements were there. So he passed flatus in stools, and then he was relieved and we had to discharge him. This was just one case. You cannot generalize them to all the cases. However, it is just to show that varus needle injury, though it is sharp and it is an injury, but it is so small that it usually does not require surgical exploration, or it does not lead to peritonitis, and there is no need to repair them. You can just manage them conservatively. That is an advantage of varus needle over the trocar or the open or Hassan's technique, in that solid organ injuries, bowel injuries, or the vascular injuries are really very small, so you do not have to manage them actively. While in the trocar, once it happens and you have diagnosed it perioperatively, then you should not remove the trocar. You just keep the trocar there. It is just helping you the site of injury, and then you see whether trocar is halfway through, whether only the tip is in, whether it is through and through the wall. So now in a trocar injury, that really needs management, and that is the way how you manage it. And if there is a single perforation, it is usually a clean injury, so you repair with extramucosal interrupted sutures, and there is no need for stoma. However, if I'm the surgeon, I would always involve a gut surgeon, and then we will see whether we are managing this perforation laparoscopically or open. If the surgeon which I'm consulting, or if for that matter, if I am experienced and confident enough, I would like to repair the gut laparoscopically and take all the precautions required post-operatively. Otherwise, you can open the case, and conversion in such cases is to kill your ego, not the patient. So it is always preferred to open if you cannot manage it laparoscopically. So that was sharp injury. Now we come to the injuries by diathermy. However, the sharp injuries can occur not because of only the trocars or the varus needle. The various other instruments like scissor can also cause sharp injuries. So those are managed in the same way. Here you can see that there is a direct coupling of an instrument by which you have grabbed the bowel, and there is direct coupling of a diathermized or energized instrument to that instrument, so it leads to indirect injury to that organ. And another important thing is this kind of injury. There is insulation failure, so there is an insulating sheath on the reusable instruments, or even the disposable instruments. So before attaching the diathermy to your instrument, you must always check the insulation. If there are small breaks or breaches in that sheath, you must not use a diathermy, because you are performing a nephrectomy. However, your instrument here near the abdominal wall is touching the small bowel or the large bowel, and due to that leak or the breach in the insulation sheath, the current is directly touching the small bowel, and you would not even know. So in these cases, there are chances of delayed diagnosis, and the mortality is quite high. Here you can see this one, that this is how it happens. Then is the capacitive injury. There is coupling. You can see here that the cannula is charged. The instrument is away; it is not touching the bowel. However, this cannula is touching the bowel, which is charged because of the seal leak of the insulation sheath that leads to bowel injury. Another thing is that when in here you can see that this bowel can be injured. You are using a plastic cannula, and there is a metallic reducer in it, and then there is an instrument which is having energy source, for that matter, a monopolar diathermy. In this case, this reducer can get capacitated. It can store charges, and these charges, when they touch the bowel or any other viscera, that can lead to injury. And in all these cases, it is extremely difficult to identify at the time of surgery, which means there will be delay in diagnosis, which means there will be high morbidity and high mortality chances because of the delayed management. So what are the principles of general management? When it is diagnosed peroperatively, if the surgeon is experienced, laparoscopically it can be managed. If there are serosal tears, you can just repair the serosa suture. If there are small transmural injuries, you can just repair them with interrupted extramucosal sutures without any stoma. And if there are major injuries, you can also resect and anastomose and laparoscopically. If the surgeon is inexperienced, you should immediately convert the case to laparotomy, and you can involve a gut surgeon if you are not experienced or confident enough. So suturing, we discussed. Resection and anastomosis should be performed if there are multiple site injuries. So instead of repairing the gut at multiple sites, it is better to resect and do an end-to-end anastomosis. That can be done laparoscopically using stapler devices. It will come later in the slides that multiple resection and anastomosis should not be performed. If the segments are near to each other, just resect that one segment and make just one anastomosis. You can cover them without stoma, or you can do a proximal stoma, which is defunction. And if there is any spillage of the peritoneal cavity, then of course you have to do a peritoneal lavage with some liters of normal saline, and also place a drain and keep the patient NBM for 48 to 72 hours, then allow only clear fluids. And then when the patient passes stools and there are no signs of leakage, you can allow them orally. So that was about the peroperative diagnosis. Now, post-operative diagnosis. Patient has signs of peritonitis and symptoms of peritonitis. There is pain, there is nausea and vomiting, there is high-grade fever, the patient has tachycardia, there is jaundice, there is low urinary output, there is tenderness, guarding, rebound tenderness, there may be a vaginal fistula, or there may be a foreigner's gangrene in case of rectal injury. So all these are symptoms and signs of bowel injury, which are diagnosed post-operatively and not peroperatively. So there are signs and symptoms, imaging and biochemical tests, and if you are in doubt, you should immediately do a laparoscopy and see what's the problem inside. So the site of injury may be duodenal, maybe stomach, duodenum, rest of the small bowel, the large bowel, or the rectal injury. The injuries to the stomach is a highly vascular structure, and you can repair the stomach primarily with the interrupted sutures. Then comes the duodenal injury. They are most difficult to treat because there is high volume of acidic fluid coming through it, and there is compromise of the lumen. So if you see that there are only serosal tears, you can just repair them. If there is a small tiny hole, you can repair the duodenum with interrupted transmural sutures with one or two sutures. But if you are convinced that after repairing of the duodenum, there will be compromise. So if it is large, if there is for that matter, a diathermy, collateral diathermy or thermal injury, like for example, you are using a scissor or a hook or even the ligation while mobilizing the duodenum from the renal vein and the inferior vena cava. And if you have used it close to the duodenum, then there is thermal injury to that duodenum, and in that case you have to refresh all the edges. And after refreshing of the edges and closure of the duodenum, if you think that the lumen is compromised, it is always imperative and important to perform a gastrojejunostomy, and a gut surgeon must be involved and to see whether you can manage this laparoscopically or you have to convert it to an open procedure. The rest of the small bowel, the basic principles are the same as already discussed. Primary closure in the form of if there are introstomies or it's erosal tears, and resection and anastomosis if more than half of the diameter of the bowel is involved. If there are multiple introstomies in short segment, then you have to, of course, resect and do an anastomosis. If the mesentery is compromised and you see that a portion of a bowel may get ischemic later on, then of course you have to do resection of that segment and do an end-to-end anastomosis. Multiple resections must be avoided. If there are punctures at different sites away from each other, you have to resect all that segment and do the anastomosis, and that may be done laparoscopically if the surgeon is experienced, or by open procedure. A gut surgeon must be involved, and a stoma needs to be discussed and decided at the time of the surgery. Then the large bowel is usually, we see that it is usually loaded with fecal matters. However, if there is a small sharp injury, you can repair it without any stoma. If there are large injuries, then primary closure or resection anastomosis has to be considered, or sometimes that segment which is injured is brought out as stoma and nothing else has to be done. And at times, if there is spillage or if the injury is has occurred to the sigmoid colon, then closure with a covering colostomy is a must. Rectal injury is a peculiar kind of injury which can occur in about 1.7% of prostatectomies, laparoscopically or robotically. And the reason for that is an improper incision in denonuvelar fascia. The proper plane is not maintained, so when you reach the apex of the prostate, you usually go into the rectum instead of going towards the urethra. So in that case, when the base is mobilized and a proper plane is created, the seminal vesicles are lifted up and the posterior surface of the prostate is visible or palpable, then the trick is that you go to the urethra and then you do a retrograde dissection after traversing the urethra. So that is the trick. If there is a small perforation, primary closure without stoma. However, in majority of the cases, a covering colostomy has to be performed. So the risk factors are large prostate, radiotherapy. So patient selection is really very important, and you must know in advance if there are previous rectal surgeries. And during the learning curve, you can injure the rectum. And the per diagnosis can be a gas. The gas will be leaking constantly per rectally. So that is one thing. And the management can be via 2-0 or 3-0 mitral sutures, interrupted or continuous, as the wish may be, and there can be coverage by a stoma or not a stoma. So what are the delayed complications of bowel injuries if they are unrecognized at the time of surgery? There can be acute peritonitis. There is a history of course, the severe pain, nausea, vomiting, and fever. On an examination, there is tachycardia. There is rigidity, there is tenderness, rebound tenderness, and there may be jaundice. In investigation, if you performed an X-ray erect abdomen, there will be gas under the diaphragm. However, since the laparoscopy has been performed, there will be gas under the diaphragm anyways, but a CT with oral and IV contrast must be performed to know the exact site and location and the extent of extravasation, and then it should be treated accordingly. And in chronic cases, if there is no peritonitis, if the peritonitis is localized, then of course there will be intra-abdominal abscesses, and there may be an enterocutaneous fistula. And duodenal injuries must be looked for immediately. One should really be away from the duodenum with diathermy or any other sharp instruments at the time of surgery. As we all know that prevention is always and always better than cure. So because duodenal injuries have got really high mortality. So the take-home lesson is the early diagnosis is mandatory, and do not underestimate, and you should not go into the operation theater with optimism when there is injury to the small bowel. You must immediately address it rather than going for optimism that it will get better. Always involve a colleague, preferably a senior colleague, and preferably a general surgeon if there is any doubt of bowel injury during the procedure. And always consider conversion. Conversion is not a failure, but it is the epic of mastery in surgery, and it is for the safety of the patient. And whenever you are in doubt, always go for a second look laparoscopy. With this, we end with the presentation. And I would like you to subscribe to my channel, Akhtar Nawaz 9699 on the YouTube. And thank you very much for listening to the lecture. Thank you.